Yes, ma'am, we can start the class.
Okay. Okay. Hi. So we're back with the short revision series, and the topic for today is neuro-ophthalmology. So you're more likely to get a short question on neuro-ophthalmology. So just some of the questions: Marcus gun pupil, optic neuritis, papilledema, optic atrophy, types of optic atrophy, amblyopia, consecutive optic atrophy. Okay, we'll be covering all of this subsequently. So, as you already know, Auricle provides you with recorded classes which you can access as per your convenience. Live classes, which are an interactive session, practical sessions for your practical exams, exam module. This is an express module that covers everything within 20 hours, and you have a book set. The foundation classes, they provide extensive learning and uh, the advantage is that you can choose accordingly, you can choose your subject and your teacher accordingly, and besides that it provides you with a revision also. Then live classes are basically for first prof MBBS exam, and they're a 45-day class. And then the express exam module is there, which covers everything in less than 20 hours. One-to-one doubts clearing sessions are a part of the live classes. Then there is a book set. There is a question bank. There are practical sessions as discussed for your practical exams. And these are the subscription plans. That is the 3 months foundation plan, the 6 months advanced learning plan, the complete learning plan, which is for 12 months, and the ultimate MBBS plan, which is for 4 years. Okay. So the rates are mentioned and you can choose your plans accordingly. You can also get a discount if you use the following coupon as shown. So, coming to the topic of today. Now, see, actually, for today's topic, basically, it is difficult to memorize, just, by heart the topic. It is, you have to understand. Okay, only then, and yet, from experience, I'm telling you that you need to revise it again and again and again. Okay, you have to understand and you have to keep revising. Okay, so let us start. It is not like, your topics like conjunctiva and, sclera and cornea that, you just have to basically, it's not very difficult. You understand, you listen to it, and you remember most of the things, like layers of the cornea, for example. Okay, it's okay. You can remember, you will remember the layers of the cornea. You once read it twice, thrice, it is something that you just know. Whereas neuro ophthalmology, first you have to understand it in depth. Okay, and you can retain it only if you keep revising it again and again and again, and you cannot by heart it. Okay, you have to understand, only then you can write your answers. So it is a difficult topic, please listen carefully, and I hope I get to teach you in detail in the subsequent classes where I can clear most of your doubts also. So starting now. So what does a visual pathway consist of broadly? Broadly, it consists of three types of neurons. Okay, it begins from the retina. The retina has rods and cones. So these rods and cones are nothing but the sensory organs for vision, right? The eye is the sensory organ for vision, okay, but then inside that there are these rods and cones. So these rods and cones are the first order neurons, right? Now, rods and cones synapse with ganglion cells. I'm not going to discuss the layers of retina over here. I'll discuss that in the subsequent classes. So rods and cones synapse with the ganglion cells. These are all neurons, right? Ganglion cells in turn have these axons, right? They're neurons, right? So their axons collect and make up the optic nerve. Optic nerve is nothing but the collection of the axons of these ganglion cells, right? So the ganglion cell axon is the second order neuron. If somebody asks you first order, second order, it can be asked in your viva. What are the first order neurons? What are the second order neurons? So the ganglion cells are the second order neurons. And thirdly, these ganglion cells reach the lateral geniculate body where again they synapse, and the optic nerve fibers emerge, and these are the third order neurons. So where are the third order neurons located? You will say lateral geniculate body. Now, the anatomy of the visual pathway. Okay, so It begins in the neuroepithelial layer of the retina. Over here, it begins. Then it goes to the optic nerve. The optic nerve consists of axons of the ganglion cells, right? It is a bundle of neurons. Then comes the optic chiasma, where some fibers of the optic nerve cross over to the other side. After the chiasma, the name of the nerve changes to optic tract. Okay? Now, fibers traveling in the optic tract then go to the lateral geniculate body, from where what emerges? The third order neurons emerge, right? These third order neurons form the optic radiations which go through several parts of the cerebrum, the cerebral hemispheres, okay, as parietal and temporal radiations, right? And finally, they go and relay in the visual cortex, which is like the CPU of all of this, okay? It processes the image, right? Now, the figure on the extreme right, it is just a detailed version of the figure in the middle. Okay. Now, what you have to note here is that this is the retina, right? Remember that the visual field is opposite, inverse and opposite. Okay. So, nasal on the retina is temporal in the visual field. That is what we see. Okay. The temporal, what we see on the right side is actually projected on the left side of the retina. You already know that, right? So this IN, IT, SN, ST are basically the four quadrants of the the four corresponding visual fields of the retina. Okay? Inferotemporal, superotemporal, inferonasal, supernasal, right? So the thing to be noted, note the colors here. The black line, this particular line in between indicates the macular fibers. Okay. This black line in the center indicates the macular fibers. Okay. Then the red line indicates what? It indicates the superior fibers. Okay. Red. Red is for the superior fibers. Superior means superonasal and superotemporal. Okay, that is the red dotted line. The blue line indicates the inferior fibers, that is inferonasal, inferotemporal, and the black shows the macular fibers. Now what you have to note here, that's it. Okay, don't look at anything else. So the red are the superonasal and the superotemporal fibers coming from each side. The blue are the inferonasal and the inferotemporal fibers coming from each side. Okay, now what is happening here in this knee of Willebrand? The optic nerve has come here in the chiasma, and some of the blue fibers are going into the other optic tract. They are crossing over, right? What fibers are these? These blue fibers are the inferior fibers. So, what inferior fibers? Inferonasal, inferotemporal, right? So, the inferonasal and the inferotemporal fibers are forming a knee here, a curve, and then going into the other side. Okay, just remember this. Besides that, what else is going to the other side? The nasal fibers, that is superonasal. Okay, only the superonasal. This is crossing over and going to the other side. Okay, so what all are crossing over? The inferior fibers and the nasal, or more specifically the supernasal fibers are crossing over to the other side. Okay, so what do the superior fibers, that is the uncrossed superotemporal coming from here, and the crossed superonasal, as you can see in red, that constitutes the superior fibers in the optic tract. Okay, and what constitutes the inferior fibers? Uncrossed inferotemporal from the same side and crossed inferonasal. See, inferonasal. These are the crossed fibers that are coming from the knee of Willebrand. Okay, Now, maximum, if you cannot remember the knee of Willy Brandt, if you cannot remember the knee of Willy Brandt and this complicated structure, at least try to remember that from the same eye, the temporal fibers do not cross, but the nasal fibers cross over to the other side. Okay, crossing of the nasal fibers occurs at the chiasma. At least try to remember that much. Okay. So the ipsilateral temporal fibers and the contralateral nasal fibers, which have come from the chiasma, that is the crossing, they have come from the other side, are then going into the optic tract and further into the proximal part of the lateral geniculate body and forming all these loops in the cerebral hemispheres and finally ending in the occipital cortex, right? Now, the pupillary pathway, even if you don't know the lesions of the pupils, you at least the named lesions you have to know. Okay, there is no doubt about that. But other if the reactions, if the abnormal pupillary reactions, you do not you have to know the pupillary pathways. This is a very important part of basic anatomy. Okay, you are expected to know what the pupillary pathway is. So what happens when you shine light on the pupil? It constricts, right? Now, this is a very complicated thing. It looks very simple. So, this constriction of the pupil in response to light is controlled by several things, starting right from your brain, that is the cerebral hemispheres, to the midbrain, and subsequently through the third cranial nerve, finally giving some fibers into the eyeball and your pupil. Okay, so it starts here. Okay, so what are the centers in the brain? The centers in the brain are known as the cortical centers. So these centers are located in the frontal and the occipital cortex. Okay, they can be either excitatory on the pupillary pathway or inhibitory, right? So this is the cortical control. See, inhibitory pathway and excitatory pathway. Okay, now they are controlling what? They are not controlling the pupil over here. How are they controlling the pupil? By controlling the pupillary center, which is the Edinger-Westphal nucleus or the nucleus of the third nerve. So where do they exhibit the excitation and the inhibition? At the Edinger-Westphal nucleus, right? What comes out of the Edinger-Westphal nucleus? Since it is the nucleus of the third nerve would come out of it. So the third nerve comes out and now the extracranial path begins. So in the extracranial path, this third nerve is going to give branches. What branches? It gives off a branch to the ciliary ganglion, it gives off a branch to the inferior oblique, and it gives a branch to the accessory ganglion. Finally, from the ciliary ganglion, some other nerves emerge and control the muscles in the pupil. So, I mean the muscles in the iris, that is the sphincter pupillae. Okay. Now, all of this is controlled by the autonomous nervous system, that is parasympathetic and sympathetic. The parasympathetic control is exerted by this Edinger-Westphal nucleus itself. It is the whole thing is a parasympathetic, which facilitates the meiosis or the constriction of the pupil in response to light. Now, what is the reverse? What happens when the reverse? What happens in dim light? Mydriasis, right? Dilatation of the pupil. So for that, something has to inhibit the parasympathetic system and something has to stimulate the sympathetic system. So let us now look at the sympathetic pathway or the sympathetic control. So the sympathetic control, now there is no sympathetic center as such. There is an inhibitory center though, which inhibits the parasympathetic system. That inhibitory center is the hypothalamus. So the center of the sympathetic nervous system for the control of the pupillary reflex is the hypothalamus. What does the hypothalamus do? It inhibits the parasympathetic center, that is the Edinger-Westphal nucleus. So Edinger-Westphal nucleus is inhibited, the stimulus for the pupillary constriction is gone and the pupil dilates, right? So this is the center here. From there, partial decussation, the sympathetic fibers are coming here. Now these sympathetic fibers travel to C8 T1 and T2. This is the major sympathetic center, or you can say the preganglionic sympathetic center. Okay, so this is present in the spinal cord roots. Now the inhibitory pathway, it also consists of neurons, right? These are all inhibitory neurons, right? So these are inhibitory neurons which make up the sympathetic pathway. Okay, so these inhibitory neurons reach the spinal cord and in the ciliospinal center. Now, the cerebrospinal center is nothing but the ventral roots of the spinal cord segments C8, T1, T2. This is known as the cervical sympathetic chain. Now, from here, the cervical sympathetic chain is going to emerge and finally synapsing in the inferior middle ganglion. It ends up in the superior cervical ganglion. Okay. Now, the superior cervical ganglion, from the superior cervical ganglion emerges the, so we have dealt with this. Preganglionic includes the nerve roots of C8, T1, T2. Ganglion, what ganglion are we talking about? We're basically talking about superior cervical ganglion. Okay, just like we talked about ciliary ganglion in the parasympathetic system. So superior cervical ganglion, what emerges from that? Postganglionic sympathetic fibers. Okay, these postganglionic sympathetic fibers, they are going to dilator pupillae, right? Not sphincter pupillae. So it is not the third nerve that is acting here. No, these fibers are coming from the trigeminal nerve. Okay, first branch of the trigeminal nerve. Basically, from the superior cervical ganglion, they make a plexus. Okay, this plexus goes into the cavernous sinus. The whole thing becomes intracranial. Okay, from the cavernous sinus emerges the trigeminal nerve, that is the ophthalmic division of the trigeminal nerve, and this ophthalmic division of the trigeminal nerve with nasociliary, long ciliary nerves and so on and so forth, and goes and supplies the dilator pupillae, thereby mediating mydriasis. Okay, the pupillary reflex, this is the pupillary, when you are asked about the pupillary reflex, you talk about the meiosis part. Okay, so starting from what is the pupillary reflex, there is light. Okay, bright light. The afferent is the optic nerve. I'll show you. The afferent is the optic nerve. Okay, the optic nerve, chiasma tract, then it does not go into the lateral geniculate body. The pupillary reflex stops there. It goes straight into the pretectal nucleus, the Edinger Westphal nucleus, and from there the efferent starts, that is the third nerve, the ciliary ganglion, and finally the short ciliary nerves. Okay. Now let us talk about the pupillary. So see, this is the pupillary reflex that I'm talking about. Okay. And the lesions. 1, 2, 3, 4 up till 12. Okay. So here, this is the afferent. What is this? This is the optic nerve. If the optic nerve is gone, it leads to a unilateral amaurotic paralysis. Amaurotic means that there is loss of the pupillary light reflex. Okay, amaurosis means loss of pupillary light reflex. Nothing to do with the near reflex and the lid reflex, which are absolutely different pathways. The problem here, in one, the problem is at the afferent limb or the optic nerve. ठीक? After that, what happens? The chiasma comes. This is the chiasma. Now, medial chiasma. If the medial chiasma is involved, what fibers are these? Nasal fibers, right? Nasal fibers correspond to the temporal half, right? So, temporal halves of both the visual fields are gone. So, bitemporal hemianopic, because the nasal field is still intact, half the field is intact. So, hemianopic paralysis, right? Then the lateral chiasma. If something is damaging the chiasma from the lateral side, then what is affected? The temporal fibers are affected. So what will you have? You will have a binasal hemianopic paralysis, right? Then we have the optic tract lesion here. This is the region of the optic tract. Now the optic tract is carrying the temporal fibers from the ipsilateral side and the nasal fibers from the contralateral side. Okay, so what will it cause? Normal pupillary reactions, because some afferent from both the sides is still intact, right? Some of the afferents from both the sides is intact. So if the lesion is here in the proximal part of, I'm sorry, if the lesion is here, then there is contralateral hemianopic paralysis. I'm sorry, I was talking about the lesion number 4, that is the optic tract. See, this is what neuro-ophthalmology does to you, right? So, come again. Here. We have dealt with the chiasma. Okay. Third, fourth, chiasma is over. You've understood bitemporal and binasal. Okay. Now, the optic tract. What do you mean by proximal? This is the proximal and this is the distal part. Okay. This is where I got confused. So, we are talking about the distal part of the optic tract, which is carrying the visual fibers, which is carrying the pupillary light reflex fibers. Okay. So what fibers is it carrying? It's carrying nasal fibers from the contralateral side, temporal fibers from the ipsilateral side. So contralateral hemianopic paralysis or Wernicke's reaction, another named reaction. What is happening is, why contralateral? The contralateral nasal fiber is gone, temporal remains. Okay, temporal is still there. What about the ipsilateral? The ipsilateral temporal fibers are gone, the nasal remains. So, what is the resulting visual field? You see, the right side of the visual field is gone. If we talk about the lesion here, the right sided visual field is gone, right? Because this side fibers are affected, so the opposite side visual field is gone. Hence, contralateral hemianopic paralysis. Understood? The same side of the visual field is same side of the pupillary reaction is paralyzed. So contralateral hemianopic paralysis. Okay, it is not binasal, it is not bitemporal. It is nasal of one side and temporal of the one side. So that half visual field is there in each eye. It may be the right, it may be the left. Okay. Then optic tract proximal part, this part. Do you see any of the pupillary fibers coming here? No. So normal pupillary reaction if this particular region of the pathway is affected. Okay, there are no pupillary reaction fibers coming. Okay, now after the lateral geniculate body, distal part of the lateral geniculate body, these fibers are going to turn and reach the pretectal nucleus. Then they're going to cross. Then they're going to reach the Edinger-Westphal nucleus, from where the third nerve is going to come out, go into the ciliary ganglion, and so on. This is about this is the diagram that you draw for the pupillary reflex pathway, right? So where were we? We had seen the proximal part of the LGB where no lesions are happening, no pupillary reaction problems are happening. Then the next lesion is pretectal nucleus. Again, pretectal nucleus, the fibers here are the same as this, right? They've just turned and reached here. So same type of reaction, contralateral hemianopic paralysis. But then the term is not Wernicke's reaction. You will say contralateral hemianopic paralysis. Okay? Pretectal nucleus. Then what happens? A decussation happens. There is a crossing over, right? So if at the decussation, if something is happening at the decussation, right here, then bilateral reflex paralysis occurs with retention of the near reflex. Now, the near reflex has not come into the picture yet, okay? The afferent for the near reflex is different and the afferent for the light reflex is different. We are not talking about the near reflex. There is no afferent for the near reflex that has come into the picture yet, okay? So, bilateral Argyll-Robertson pupil results. Now see, whatever fibers are coming, the lesion is here, okay? Whether crossed, uncrossed, everything is damaged over here. The crossed and the uncrossed fibers, because the whole bundle is damaged over here, right? It's not on one side, it is the whole thing. It is the crossing that is affected, right? If the crossing is affected, there will be bilateral reflex paralysis with retention of the near reflex, and this is known as bilateral Argyll-Robertson pupil. Now, if the lesion does not happen at the central decussation, but at one side of the central decussation, a unilateral Argyll-Robertson pupil results. Okay, only ipsilateral abolition of light reflexes. That is known as unilateral Argyll-Robertson pupil. An easy way to remember Argyll-Robertson pupil is ARP, meaning A for accommodation, R for reflex, P for present. Accommodation reflex present or near reflex is present. Light reflex is gone. Okay, so remember the mnemonic ARP for Argyle Robertson pupil, which is accommodation reflex present. That is, the near reflex will be present, the light reflex will be gone. Okay, so until here, up till here, what was happening is that the afferent limb of the pupillary light reflex pathway was being involved in some way or the other. What happens from the Edinger-Westphal nucleus onwards? The Edinger-Westphal nucleus is involved in the efferent limb of both near reflex as well as light reflex. So if a lesion is happening at the Edinger-Westphal nucleus, it will lead to absolute pupillary paralysis, that is, even the near reflex will be gone. Okay, Edinger-Westphal nucleus, right? Ipsilateral, that is if one side of the nucleus is affected. What about third nerve? If the third nerve of one side is paralyzed, again, the entire efferent limb is gone. There is no supply to the sphincter pupillae. Again, absolute pupillary paralysis. Okay. Near reflex as well as light reflex is gone. The efferent of the near reflex is the third nerve only, but it is also the efferent for the light reflex. Until now, there were problems only in the afferent limb, but now there is a problem in the efferent limb. So both will be gone. Understood? And that would happen when there is a lesion in the Edinger-Westphal nucleus or the nucleus of or the third nerve, which comes out from the Edinger-Westphal nucleus. And lastly, we have a lesion here in the ciliary ganglion. Okay. Now here there is abolition of light reflex. Yes, because the third nerve fibers are coming, they are carrying the light reflex, that is gone. Retention of near reflex. Why? Because here again, some of these fibers have already decussated from here and gone to some other ganglion, that is the accessory ganglion, which is responsible for the near reflex. So the lesion has occurred after that. Hence, only the light reflex is gone, the near reflex is retained, and sometimes what happens is that the pupil remains in a state of tonic contraction, and that is known as Addy's pupil. So, Wernicke's reaction, Addy's pupil. Okay, right. Now, coming on to the visual pathway lesions. This will be like a revision of the pupillary reflex pathway lesions. Okay, so let us see. I'll show you the pathway once again. So, visual pathway lesions, there are certain terms that you have to be familiar with. Anopsia or anopia. Anopia means loss of vision in one visual field. Right anopia. Remember, when we talk of visual fields, our right is the patient's right. Okay. And so this is right for us as well as right for the patient. Okay. Our right is the patient's right when you talk of visual fields. So right anopia. Hemianopia, loss of field in one half of the visual field. Now, this was the right eye in one visual field or eye. Okay, that is anopia, right anopia. The whole visual field is gone. What happens here? Only the right side of the visual field is gone. So, homonymous hemianopia. Okay, only the right side visual field is gone. Now, this homonymous hemianopia can the hemianopia, I'm sorry, can be heteronymous or homonymous. Homonymous means that in both the eyes, same side of the visual field is gone, either the right visual field of both eyes or the left visual field of both eyes. And where was this happening? Remember, this was happening in the lesion of the optic tract, right? Heteronymous hemianopia, now this was happening, if you remember, at the lesion of the chiasma or the crossing. Okay, it would be nasal of one side and temporal of one side, or so I'm sorry, nasal of both the sides or temporal of both the sides. And this would happen in cases of lesions of the chiasma, whether nasal or temporal. Okay, lesions of the optic tract would cause homonymous hemianopia, that is the same side of the visual field will be lost. Quadrantopia, loss of vision in a quadrant of the visual field. Now, this is superior quadrantopia or pie in the sky pattern. Okay, pie in the sky, right? And inferior quadrantopia, this is pie on the floor. Very favorite Viva question. So when does this quadrantopia happen? It usually happens when damage to the parietal or the temporal optic radiations. Now, homonymous hemianopia again can be either complete or incomplete. Okay. So what we saw here, hemianopia, this is a complete homonymous hemianopia. Okay. The complete visual field is gone, right? It may be incomplete as in the next diagram. See, only half of the right sided visual field is gone, but then it is equal, right? Equal amount of the visual field is gone. That is known as congruous. Okay. So defects are identical in size, shape. So this pie on the sky and pie on the floor is a congruous homonymous hemianopia, and incongruous when the defects are dissimilar. In this case, the lesion would be something like, maybe a little bit of this is involved. Okay, so this happens in the optic tract and the lateral geniculate body lesions. Remember, visual fields and retina have an inverted and reverse relation. Okay, no rocket science there. Now, lesions of the optic nerve. Okay, so these were just some terms. All right, this thing, sorry, anopia, hemianopia, quadrantopia, all these were just terms. I'll show you the lesion, I'll show you the pathway and make you understand the lesions again. Okay. Here is the pathway for you. So let us start with lesions of the optic nerve. Now here we are talking about the visual pathway. Okay. So lesions of the optic nerve. What is optic nerve? Optic nerve is the afferent limb. Okay. This is the optic nerve or the afferent limb over here, right? So what happens? Anopia, loss of vision in the full visual field. Okay. Loss of vision in the right visual field is right, left is lot of loss of vision in the left visual field. Simple, right? The whole afferent pathway is gone. Remember, I'm not talking about the pupillary reflex here. I'm talking about the visual stimulus or what we see. Okay, what we actually see, not the pupillary reflex. Forget about the pupillary reflex right now. The visual pathway we're talking about. So if the afferent is gone, blind. Okay, amaurosis. So the optic nerve is affected, afferent gone, complete anopia in that particular eye. Now, lesion of the proximal part of the optic nerve near the chiasma. That is this. If the lesion is happening over here, then what is happening is that this side afferent limb is completely gone. But some of the fibers, some of the afferent fibers of the opposite side, which fibers? The inferonasal fibers. Okay, the inferonasal fibers are also gone because the knee of Willy Brandt is involved here. So what will this cause? It is going to affect only the inferonasal field. So I'm sorry, they were infranasal fibers, so it's going to affect the superotemporal field, the opposite field, right? This type of field defect is known as a junctional scotoma. Why? Junctional because it is happening at the junction, right? This is the junction we're talking about. Chiasma, proximal chiasmal lesion. Hence, junctional and scotoma. Scotoma is basically a non-seeing area in the visual field. So this is a junctional scotoma. Okay, junctional because the lesion is happening here, where one side afferent limb is completely gone, whereas the other side partly gone. So this type of visual field results. Okay, left visual field completely gone, right visual field partly affected, hence junctional scotoma, right? This happens in cases of traumatic avulsion or optic atrophy. Clinical feature: ipsilateral anopia, ipsilateral loss of direct pupillary reaction. Okay, again look at the slide. Ipsilateral pupillary reaction is lost. Contralateral loss of consensual pupillary reaction because of the crossing of the fibers, and near reflex is intact. You know why. Now, lesions of the optic chiasma. This is what happens in the lesion of the optic chiasma. The visual pathway lesion and the pupillary reaction lesion is similar. Okay. Binasal hemianopia, if the temporal part of the chiasma, if the temporal fibers are affected. it would lead to binasal hemianopia. This is less common when compared to bitemporal, okay? Less common than bitemporal hemianopia. Usually, clinically, when patients of pituitary tumor come to you, you will see this, okay? So, bitemporal hemianopia when the nasal fibers are involved, as in the case of pituitary adenoma, craniopharyngioma, chiasmal arachnoiditis, fracture base of skull. And when will you see a binasal hemianopia? Third ventricular enlargement, atheroma of the carotids. Okay. So very important viva question. Everybody is able to tell bitemporal hemianopia, but binasal hemianopia, the example we often forget, and it is also less common. So remember, third ventricle enlargement. So pituitary adenoma. Now again, pituitary adenoma can cause this pie. There are two tumors, okay, happening in the pituitary. Pituitary adenoma and second one, craniopharyngioma, right? Both of them produce similar type of hemianopia. What is the difference? Mind you, pituitary adenoma. Now, adenoma is compressing the anterior part of the chiasma, this part, okay? So what do you have in the anterior part? You have mostly the supranasal part that is being affected, right? So since the supranasal part, the nasal part, is affected, the temporal field will be involved, okay? So the problem begins anteriorly, that is, the superior fibers are affected first, supranasal, right? So the superior fibers are going to be affected first, and then it is going to progress to involve the whole of the temporal field slowly, okay? Hence, pi in the sky. Ultimately, this pi in the sky is going to be a bitemporal hemianopia, finally. But initially, it will be a pi in the sky pattern, right? Now, remember, a pi in the sky pattern will also be seen in temporal lobe radiation lesions, okay? So a pituitary adenoma will cause a pi in the sky initially, but later on it's going to cause a bitemporal hemianopia. Okay. Reverse for craniopharyngioma. If a tumor is compressing the chiasma posteriorly, then the superior fibers are affected first, so that the lesion actually begins in the inferior field and crosses the horizontal midline and slowly leads to again bitemporal hemianopia. So remember, pituitary tumors are going to cause bitemporal hemianopia ultimately. Okay, this is a bitemporal hemianopia, right? This is what a bitemporal hemianopia looks like. So all pituitary tumors will cause bitemporal hemianopia. But if you are able to tell which one actually causes pi in the sky initially and which one causes pi on the floor, you get bonus marks. Okay. Now, lesions of the optic tract. These lesions cause homonymous hemianopia. Okay, we've already seen that when we saw the pupillary light reflex pathway. So RAPD, what does RAPD stand for? Relative afferent pupillary defect. Okay. Relative afferent pupillary defect, you have to read up about the swinging flashlight test. This is also known as Marcus gun pupil. Okay. So basically, when you shine light into the pupil of the affected side, the pupil, instead of constricting, dilates, right? Read up about the swinging flashlight test. I wish I could teach you in this short span of time. I could teach you everything, but then there is something that you have to read up. So read up about Marcus gun pupil and RAPD. RAPD is going to be present in all lesions that start from the optic nerve, optic tract, optic chiasma, and optic tract. RAPD is going to be present. If associated with right hemiplegia, sometimes this lesion of the optic tract is going to be associated with right hemiplegia and third nerve paralysis because they lie close by. These structures lie close by. Examples of optic tract lesions, these are some of the examples of optic tract lesions. Okay. Now, lesions of the lateral geniculate body, again homonymous hemianopia with sparing of the pupillary reflexes, because as we know, the pupillary reflexes leave the lateral geniculate body and go to the pretectal nucleus and then the Edinger-Westphal nucleus. So pupillary reflexes will be spared, but the visual field will be affected. Okay, these lesions are relatively rare. Then we come to lesions of the optic radiations. Okay. So when we talk of the visual pathway, the lesions, they just enter the lateral geniculate body and then they leave it. They do not leave the lateral geniculate body. When we talk of the visual pathway, they don't leave the lateral geniculate body. They enter the lateral geniculate body, and from there they reach the um, optic radiations. Whereas when we talk of the pupillary light reflex, the pupillary fibers leave the lateral geniculate body and enter the pretectal nucleus and Edinger-Westphal nucleus. I'll repeat myself. The pupillary fibers leave the lateral geniculate body to go to the pretectal nucleus, Edinger-Westphal nucleus, and so on. Whereas the visual pathway fibers from the lateral geniculate body proceed on to the optic radiations. Okay, please remember that. That is the main difference between the visual pathway and the pupillary pathway. So lesions of the optic radiations, if the temporal lobe, I already told you this, if the temporal lobe is affected, pie in the sky. Now this is because of the fibers that are traveling there. Pie in the sky or superior quadrantopia is happening because the inferonasal fibers are passing through the temporal lobe, and that is also known as the Mayer's loop. Okay, these fibers, these inferonasal fibers are also known as Mayer's loop. So you can get a MCQ, you can get a Viva question that what is Mayer's loop and what happens if there is a lesion there. Pie in the sky. Remember, temporal is inferior. So superior quadrantopia. Then parietal lobe, pie on the floor. The reverse happens. An occipital cortex, homonymous hemianopia with sparing of the macula. Now, why sparing of the macula? Because most of the occipital cortex is going to be supplied by the posterior cerebral artery, whereas the macular part, a small area, is supplied by the middle cerebral artery. So the macula, that is the region supplied by the PCA, is the occipital cortex. Okay, that is gone, but the region supplied by the MCA is still there. That subserves the macula. So macular sparing is seen in lesions of the occipital cortex. Common causes of lesions of optic radiations, that is that pie in the sky and pie on the floor that we were talking about. Vascular tumor, vascular occlusions, cerebral tumors, and fall on the back of the head. Okay. Remember, these lesions do not produce optic atrophy because they are third order neurons. They are congruous and the pupillary reactions are normal because the pupillary fibers have already left and gone to the pretectal nucleus. Congruous. Now, these are congruous because the fibers of the optic nerve have now become very compact. Okay. Unlike the optic tract lesions, which are incongruous because the fibers are spread. When it comes to the optic radiations, these fibers become aligned and compact. That is why optic radiation defects produce congruous defects. Whereas when the fibers are in the optic tract, they are spread out. So the defects are not congruous or they are incongruous. And no optic atrophy happens. Remember this. Field defects in the lesions of the visual cortex. Now, this usually happens when there is a stroke that affects the visual cortex or the posterior cerebral artery stroke. So, if the tip of the occipital cortex is involved, this is a central homonymous hemianopia that is happening. That is, in this case, the tip which is not supplied by the posterior cerebral artery but by the middle cerebral artery is affected and macula is affected. So, there is a central defect now. Okay. This part is supplied by the MCA and it subserves the macular area. MCA, macular area. Okay. Anterior visual cortex supplied by the posterior cerebral artery. So macular sparing happens and anterior most part of the visual cortex. Now this is very, very rare. It's okay. Remember these two diagrams and remember the causes. The causes are the same. The same causes that affect the optic radiation. It is everything is in the cerebrum only, no? So the causes that affect the radiation are going to affect the causes that affect the optic radiations are the same as the causes that affect the occipital cortex. Okay, everything is in the cerebral hemisphere. So same causes: vascular lesions, trauma, tumors, right? 3 lesions. Clinical presentation in visual cortex, there are certain terms that you have to know. Anton syndrome, the patient denies blindness. Okay, there is denial of blindness. So since the cortex has come into the picture, higher functions are going to be affected. That is why these things like denial of blindness, appreciation of motion in the blind field or redox phenomena, and word blindness, alexia. These things are coming into the picture because the cortex is involved, and since the cortex is involved, some higher functions are also going to be involved. That is why, in cases of visual cortex lesions or cortical blindness, these things will happen. And what do you have to do? You have to examine the reading ability whenever you have a case of right hemianopia, that is left occipital lesion. Whenever there is a case of right hemianopia, you have to rule out an occipital cortex lesion by doing this. Okay. A right hemianopia can be seen in case of optic tract lesion also, right? But you have to differentiate between the two. How to differentiate whether right hemianopia is happening because of the optic tract lesion or the optic occipital cortex lesion? This is how you differentiate. These things are going to be present only in the optical occipital cortex lesions. Okay. More differences between the occipital cortex or the occipital lobe, same thing. Cortex or occipital lobe. Because why are we differentiating? Because both are causing hemianopia. What is the common thing? Hemianopia is common, right? So how to differentiate? Those three things I've already told you: Anton syndrome, Redox phenomena, alexia. They will be present in the cortex lesions, whereas not present in the optic tract lesions. What are the other differences? Pupillary reaction. Occipital lobe lesion, normal. Optic tract lesion, abnormal. Why? Pupillary fibers traveling in the optic tract, right? They leave the lateral geniculate body. We have not come there yet. Optic tract is before the lateral geniculate body. So pupillary reaction will be abnormal, whereas occipital lobe, it is way behind. Okay, it is the back of the head, right? No pupillary reactions over there. No apparent, no efferent. Pupillary reaction is normal. Field effect, I told you, congruous. Optic tract, incongruous. I told you the reason already. Macular involvement, macular sparing, macular involvement in optic tract, macular sparing in the occipital lobe lesion. Why? Because the tip is supplied by the middle cerebral artery. And optic atrophy does not happen here. Remember, third order neurons involvement is not going to cause optic atrophy. Optic atrophy is going to happen only in first and second order neuron lesions. Whereas in the optic tract, what is the optic tract? The first order neurons only, na? So they are going to be affected. Okay. Remember these differences. Now we come to optic neuritis, papilledema, and optic atrophy. This is the easy part. The hard part is over. So basically, a lot of brainstorming has to be there when you get questions of visual pathway and pupillary light reflex. See, at a point of time, even I was confused. So it is normal. It is difficult. Please keep on revising again and again and again. Right? The visual pathway, at least you have to know the visual pathway and its lesions. The homonymous hemianopia, it should be on your fingertips. For the pupillary, as far as the pupillary reactions are concerned, just remember the few names. And since you have to, and for those names only, you remember where the site of the lesion is. Marcus gun pupil, when will you see a Marcus gun pupil? When will you see an Addy's pupil? When will you see a Wernicke's reaction? So on and so forth. What is an RAPD? RAPD and Marcus gun are the same thing. So these named reactions, at least know the site of the lesion. Okay, as far as the pupillary pathway is concerned, the pathway itself obviously you have to know. But in case of visual pathway, you have to know the pathway very well as the lesions. Okay, the pathway begins from the optic nerve, retina, optic nerve, chiasma, optic tract, lateral geniculate body, optic radiations, occipital cortex. That is a visual pathway, right? The pupillary light reflex, rods and cones, optic nerve, okay, chiasma, tract, then before reaching the lateral geniculate body only, comes out pretectal nucleus, Edinger-Westphal nucleus, third nerve, sphincter pupillae. Okay, two different things, two different pathways. That is why near reflex may be retained in the pupillary reaction, and the visual pathway lesions will not always go hand in hand. Okay, because the pupillary fibers leave the lateral geniculate body. Just remember this much. Okay. Now, optic neuritis, papilledema, optic atrophy, it's just go through. So this is what a normal optic disc looks like. This is the disc and this is the cup, and these are the central retinal vessels. Okay. Now, optic neuritis means inflammation of the optic nerve. As the name suggests, it can happen secondary to demyelination, infection, or autoimmune pathology. Classification, according this is the anatomical classification. Papillitis is when this part of the optic nerve is affected. Retrobulbar neuritis is when the postlaminar part of the optic nerve is affected. It can be acute or chronic. Neuroretinitis, as the name suggests, retina is also involved. Okay. And neuro means optic nerve, and then perineuritis. Okay. So etiology, idiopathic in most of the cases, multiple sclerosis. Okay. 70% cases of optic neuritis occur in established case of multiple sclerosis. There are these two named phenomena that you have to remember. UTOFs is impaired vision when the body temperature increases, such as with exercise, and pulfrish is altered perception of moving objects. Remember, you may be asked these things in Viva. If not Viva, you have to remember the names of these phenomena and their meaning for your MCQs, which are going to be important in your entrance exams. Okay. Neuromyelitis optica or Devick's disease is one cause. Hereditary optic neuritis or Leber's disease seen in children. Post-viral, metabolic causes, toxic, which includes these drugs, alcohol, of course, ischemic, granulomatous inflammation, that is sarcoid, TB, syphilis. These things you're going to find in your books, okay? So I'm not going to elaborate on the causes. Now, clinical features of optic neuritis. The optic nerve is inflamed, okay? So what do you think will happen? The visual acuity would decrease, obviously. There will be local tenderness. Now, what is attached to the optic nerve? The sheath, that is the tenons that we are talking about. That sheath is below the sclera, that tenons capsule. Now, the sclera is the itself is continuing behind as the optic nerve, right? The sclera is the outermost coat of the eyeball. Muscles, extraocular muscles are attached to the sclera. That sclera only is continuing behind as the sheath of the optic nerve, right? The dura mater, right? So if the structure is continuous, then any movement of the eyeball is going to cause pain because the optic nerve is affected, right? So move because the sclera is continuous with the dura mater of the optic nerve. So movements of the sclera, which is happening because of movements of the eyeball, are going to cause pain over there also. Okay. Pupillary reaction, RAPD, of course, optic nerve is involved, so RAPD will be there. Impaired color vision, impaired contrast sensitivity, delayed dark adaptation. These are some of the other functions of the optic nerve, not just vision. Vision is not the only thing that the optic nerve does. And visual field, of course. Okay, the visual field is going to have scotomas, right? What are the symptoms? Blurring of vision, loss of vision. Okay, it can be an adult or it can be a child. It is sudden. Okay, uniocular, sudden loss of vision or diminution of vision. Visual loss usually maximum by end of the second week, but starts to improve by 4 weeks even if untreated. And discomfort or pain behind the eyeball, especially when moved superiorly. This corresponds to the local tenderness that we were talking about here. Why local tenderness is happening? Because the sclera is continuous with the dural sheath of the optic nerve and the extraocular muscles are attached to the sclera. What do you see in ophthalmoscopy? See, this is an inflamed optic nerve. Okay, this is a case of optic neuritis. You see some hemorrhages here. These are hemorrhages, these dark red things. Okay, they look like this. Okay, they are splinter shaped hemorrhages. They look like this. So engorged edematous optic disc. Why edematous? Because you cannot make out the margins. Obliteration of the cup, small hemorrhages. Retrobulbar neuritis, the inflamed part is behind the lamina cribrosa, so you cannot see it with the fundus on the fundus picture. That is why no signs, but what will be there? Pain on extraocular movements will be there. And neuroretinitis. As the word suggests, something in the retina will also be involved, and that is what is shown by macular star. Differential diagnosis, papilledema and pseudopapillitis. This is the differential diagnosis of pseudopapillitis, that is high hypermetropia in which you have a crowded appearance of the optic disc because the eyeball itself is small. Myelinated nerve fibers, which can also cause blurring of the optic disc in some part where the nerve fibers are there. And optic nerve head drusen. They can also cause blurring of the disc margin. Okay. So these three things can cause blurred appearance of the disc margin. It doesn't mean that the margin is obliterated, that is seen in edema. So papilledema, pseudopapillitis are two DDs. Investigations: you will do a contrast. When a contrast enhanced MRI of the optic nerve is done, you will see a fat inflamed nerve which is picking up contrast. That is suggestive of inflammation. Okay. What is VEP? VEP is visually evoked potential. It is a investigation used to test the function of the optic nerve. And what will you see on the VEP? You will see a reduced latency. Basically, VEP is affected. Remember what investigation you'll do? You'll do a visual evoked potential, and that will be affected in case of optic neuritis. Course and prognosis, I already told you, it will resolve in 4 weeks on its own. But some higher functions such as color vision defects, contrast sensitivity, visual field defects may persist. Okay. Treatment: if there is an underlying cause, you treat it. Nevertheless, you will give a steroid because it is an inflammation and steroids are anti-inflammatory. So first we give a bolus dose of 1 grams per day for 3 days, and after that we gradually taper it. All of you know that steroids cannot be stopped after giving a high dose. You can only taper the steroids. And of course, supportive therapy for whatever underlying systemic problem is there. Next, we come to papilledema. So that was optic neuritis. Now, papilledema. Remember, disc would appear blurred or swollen in both the cases. Optic neuritis versus papilledema. It is clinically also very difficult to differentiate. Okay, you can memorize these things theoretically, you can write your exams, but clinically it is a difficult job to differentiate. Okay, so definition of papilledema: first, bilateral. Optic neuritis is usually unilateral. Okay, but in science everything overlaps. Okay, so this is what practically what the thing is I'm telling you. But for your exams, remember, bilateral papilledema is bilateral, non-inflammatory. Okay, that was inflammatory. The word neuritis, itis was there. Passive swelling of the optic disc. Why passive? Because the optic disc itself, there is nothing wrong. Something is something is coming from behind and pushing it. That is the raised intracranial pressure. Does not develop if the optic nerve is atrophic, of course. Okay, so Foster Kennedy syndrome. Now suppose the optic nerve on one side is dead. Okay, then what happens if the intracranial pressure increases? It is transmitted to the optic nerve sheath, but one nerve is already dead, right? So nothing is going to happen there. There is no swelling. The nerve itself is dead. So where will the edema happen, right? But edema would happen in the other eye. So when you look at it, you will find that there is contralateral papilledema with ipsilateral pressure atrophy of the optic nerve, and this happens in case of frontal lobe tumors. Okay, that is, the tumor is causing increased intracranial pressure, but on the same side of the optic nerve, it has caused atrophy. It has caused so much of pressure that the nerve has died out. But on the other side, it is causing edema because of increased intracranial pressure. So why optic atrophy on one side? Because the nerve on that side, because of direct pressure of the tumor, is already dead. There is no place for edema to happen. Okay, this is known as Foster Kennedy syndrome. DD of disc edema, obviously papillitis and neuroretinitis. Then there is something known as anterior ischemic optic neuropathy, optic nerve glioma, meningioma, and central retinal venous occlusion. Okay, just some DDs you have to remember. So etiology of papilledema: elevated intracranial pressure due to any cause. What happens? Prelaminar optic nerve. By prelaminar, I mean the part that is behind the part that has not entered the eye yet. The part behind the lamina cribrosa is prelaminar. So prelaminar optic nerve is affected by changes in tissue pressure, IOP, and CSF pressure. Okay, so if the CSF pressure or the intracranial pressure increases, as I told you, because the dural sheath is continuous, it's going to get transmitted to the optic nerve. So that tissue pressure is going to affect the axoplasmic flow, which is carrying out the metabolism of the optic nerve. Hence, there will be swelling. Okay, and increased pressure on the prelaminar capillaries and small veins are going to cause venous stasis, even worsening the condition. So ultimately, there is increased congestion and edema. Okay, initially it is axoplasmic flow is compromised because of mechanical pressure, and gradually even the blood vessels are compromised or compressed, and that just worsens the compression and leads to more and more edema, and it becomes a it becomes a vicious circle sort of thing. So general symptoms. Now, why are we talking about general symptoms here? Because papilledema has some systemic cause, no? Something is increasing the intracranial pressure. So whatever is increasing the intracranial pressure is going to affect the other parts of the body also, and not just the eye, right? So headache, often made worse by coughing or straining, vomiting, and some focal neurological deficit in the form of, some localized paralysis, limb paralysis, something. Ocular symptoms. Now, visual acuity is normal until late stages, unlike optic neuritis, where the visual acuity is often worse in the first 2 weeks and normalizes in the later stages. Transient blurring may be seen, and in 25% patients, visual symptoms are going to occur only in severe papilledema. Signs. Pupillary reactions are normal until secondary atrophy or optic atrophy sets in. Other signs: blurring of the margins of the disc in this order: disc hyperemia, splinter hemorrhages, the optic cup anatomy is preserved. Okay, so this is papilledema versus a normal optic disc. Papilledema has four stages. Okay, established papilledema, chronic papilledema, atrophic papilledema. Okay, these are the three stages. Early papilledema, you don't see anything. Established papilledema, you're going to see the margins are indistinct and the cup is obliterated. Surface elevated up to more than +3 diopters, it becomes hyperopic, no? Because that part of is has become short. So a +3 diopter hyperopia happens when you see it with the direct ophthalmoscope. Flame shaped hemorrhages. This one is a flame shaped hemorrhages. See, this is the shape of the flame shaped hemorrhages. Cotton wool spots, venous engorgement, and peripapillary edema, and Patton's lines. These are Patton's lines. Okay, and of course macular star. With progression, it becomes chronic, so the central cup remains obliterated, whereas the hemorrhagic and the exudative components resolve, and atrophic when optic atrophy sets in, and you don't see any hemorrhages, you don't see any swelling, nothing, just a pale white disc. Visual fields, again early, no changes. Established, a blind spot. Chronic, peripheral constriction of the field, and atrophic, complete loss of the field. So please read up differences between, this is just a summary of the differences we've already discussed in the previous slides. So read up the differences between papilledema versus optic neuritis. Okay. Treatment for papilledema, you have to treat the cause, and the cause is an increased intracranial pressure, and that would reduce if you give a hyperosmotic agent such as acetazolamide. Okay, what is acetazolamide? It is a carbonic anhydrase inhibitor. If required, surgery may be needed to decompress the optic nerve. Last topic of the day, optic atrophy. Just very quickly, there's nothing to understand much here, just three types of atrophy. So this is the definition: degeneration or death of the optic nerve fibers with loss of their myelin sheaths, characterized by pallor of the optic disc due to loss of vascularity owing to obliteration of disc capillaries. Okay. Symptoms: gradual or rapid loss of central, then peripheral vision, peripheral, then central vision, impaired color vision. Signs: visual acuity is impaired in proportion to the degenerated nerve fibers, RAPD in unilateral optic atrophy, and ultimately the pupil is dilated and immobile, no reaction at all. So a primary atrophy, in a primary optic atrophy, it's a chalky white disc. Okay, there is no local cause for the atrophy. It is usually associated with CNS disease. Commonest cause: multiple sclerosis, Leber's optic atrophy, nerve compression by a tumor, injury to the retrobulbar part. Signs: chalky white disc with well defined margins, absence of small blood vessels. Glaucomatous optic atrophy will have a deep excavated cup, which is the classical feature of glaucomatous optic atrophy. It is also known as a cavernous optic atrophy, and besides that, other features like bayoneting sign and nasalization of blood vessels, etc., will also be there. Secondary optic atrophy is preceded by swelling of the optic disc, that is papilledema, optic neuritis, or neuroretinitis. That is, if there was a swelling. So this was the optic atrophy in the previous slide. See, this is the last stage, atrophic papilledema. So this is a secondary optic atrophy, right? That is atrophy that happens secondary to disc swelling. And finally, we have consecutive optic atrophy, which is happening because of a result of retinal disease, right? Then anatomical classification, ascending and descending. Why ascending, descending? Ascending means that the lesion begins in the retina. Okay. Descending means that the lesion begins at the level of the LGB or beyond it and terminates in the retina. Okay. So ascending and descending, another classification. Differences between primary optic atrophy and secondary optic atrophy. Okay. Secondary happens post disc edema. Primary happens on its own or because of some demyelinating disorders. So it is easy to remember the differences. This is chalky white. This is dirty gray. Why dirty gray? Because some pathology, some disease has already happened to the optic nerve. Margins sharply defined, blurry because they were blurring to begin with. Cup is okay. It's obliterated here because again there was edema. Laminar dots visible, not visible. Glial proliferation more marked because there was inflammation, right? So following that there will be fibroblasts. So glial reaction will be more marked in secondary. Vessels, no sheathing here, sheathing present in this case again because of inflammation. Previous disc edema absent, present. Okay. Consecutive optic atrophy is that which happens secondary to a retinal disease. In this case, it is RP. Okay, you can get a short note. So, treatment optic atrophy, the vision is so poor that you cannot correct it with glasses or any kind of refractive correction. You have to give something known as low vision aids, and that is a separate topic, and you'll have a separate class on that. They are basically in the form of magnifiers, telescopes, and things that increase brightness and visual field and so on. Okay, it is a rehabilitation, it is not a treatment. So that's it for the class today. I'll just summarize. Visual pathway and lesions, pupillary pathway. I think I've talked enough about those. Abnormal pupil reaction, Argyll Robertson, Marcus Gunn, Addy's pupil, and Wernicke's reaction. Remember that also. Optic neuritis types, that is papillitis, retrobulbar neuritis, and neuroretinitis. That is the types. Causes, there are so many causes. Imaging, you'll see an inflamed nerve on MRI, and VEP will show reduced values. And treatment would include treatment of the underlying cause and bolus steroid followed by oral. Okay. Papilledema, disc swelling secondary to increased intracranial pressure, bilateral, it has stages. Foster Kennedy syndrome, optic atrophy in one eye, edema in the other, secondary to some space occupying lesion, and differences from optic neuritis. Optic atrophy types, primary, secondary, consecutive, and glaucomatous, four main types. Okay, and that's about it. So, thank you very much for listening.
Thank you, ma'am.
Okay.